Just a quick note, I put up all of these slides into this voice thread, but I'm only going to talk about the ones that I said I would in class. So there's going to be all of the drugs, immunizations, um, and then um, wound healing, which I actually didn't mention in class, and complement cascade. So just to be aware that you're going to see all the slides, but there's not going to be talking over all of the slides. Okay, when it comes to the complement cascade, we're going to go into a little bit of detail, but for the test, there's only three things you need to know. First one is, what is it? What does it do? And how is it activated? So, what is it? What does it do? How is it activated? So, the complement cascade is a cascade. It's a series of enzymes. Now, the reason that you have a cascade is to avoid having it activate inappropriately. So, when you have a cascade of zymogens, remember, a zymogen is an enzyme that is inactivated. So in the cascade, one of them is going to become activated. That's going to activate another. That's going to activate another. That's going to activate another. And then the final thing will occur. So what you need to know is what the final thing is and the first thing, how it starts. So in this little diagram, we have what's called the final common pathway. It doesn't matter how the complement cascade is activated. We're going to end up with these little C6, C5b fragment, and C7 coming together to form a little complex. That complex is going to stick to the surface of the membrane of the cell. Then that membrane is going to use C8 like a drill and is going to drill it through the cell wall. Then from C8, there's going to be a series of C9s put into place in a ring formation. So eventually it's going to look like this. So basically it's popping a hole into the side of the pathogen. Um, and that's going to allow the insides to become outsides. Or, to quote A Knight's Tale, their entrails will become extrails. So here you can see a micrograph of it, and you can see right there is the C9 complex ring that's poking a hole into this particular cell, and that's going to end up killing it. In addition to poking the hole into the membrane and rupturing it, it's also going to act as an opsonin, and that's going to attract macrophages to come and eat this particular cell. So, the this particular ring is called the membrane attack complex, or the MAC. So, what you need to know is that the complement cascade is going to kill pathogens by poking holes in them. What does the poking? The membrane attack complex, or MAC. The other thing that it's going to do is act as an opsonin to attract macrophages to the area, and it will also increase the amount of inflammation in the area. So, three things that complement does in the end: pokes holes in cells through the membrane attack complex, acts as an opsonin, and increases inflammation. The other thing you'll need to know about complement cascade is the three pathways that it can be activated. The first one is called the classical or classic pathway, and it involves C1. C1 is, these were named not necessarily in the order that they work, but more like the order that they were discovered. So C1 was the first one discovered, and C1q is the actual receptor portion that binds to something. So when C1 binds to something, that's going to cause the classical pathway to be activated. Now, there are three somethings that it can bind to. It can bind to phosphocholine, which is a substance inside the cell wall of many bacteria. It can bind directly to certain pathogens, but the most common thing it's going to bind to is it's going to bind to antibody antigen complexes. So, remember last week when we talked about antibodies and the four functions of an antibody? Function number 2 was to activate complement. So, when the antibody sticks to an antigen, that is going to allow C1 to bind to it, activating complement through the classical pathway. The second pathway is called the mannose binding lectin pathway. Mannose is a sugar substance, sugar molecule that's found in the cell wall of certain bacteria. So, when you have inflammation, your liver is going to produce this protein called mannose binding lectin. If that particular protein binds to a bacteria, then that can activate the complement cascade. The third and final way is what's known as the alternative pathway. And the alternative pathway is sometimes called spontaneous pathway, and it doesn't involve, it just kind of sort of happens. I'm sure there's more to it than that, but from our perspective right now, we don't really know why it just happens, but it just happens. Um, so, to summarize, there are three basic pathways: the classic pathway, the mannose binding lectin pathway, and the alternative pathway. The classic pathway, C1 is going to bind to one of three things: the pathogen directly, C reactive protein, which binds to phosphocholine, or to an antigen antibody complex. Before we can talk about septic shock, what we need to talk about is a substance known as TNF alpha, tumor necrosis factor alpha. The reason it's called tumor necrosis factor is because it inhibits the growth of tumor and can kill them. However, it does much more than that. It is one of the primary cytokines that is released by macrophages. It's going to cause a couple things to occur. It's going to cause vasodilation, it's going to cause increase in vascular permeability, and it's going to cause an increase in clotting activity. Now, in a local inflammatory response, this makes a lot of sense. You want to get blood to the area, you want to allow antibodies and complement cascade to go into the area so that they can fight off whatever's there, and you want to clot that area off so that um, whatever's whatever is happening is localized to that area. So it's going to prevent the bacteria from getting inside. So TNF alpha is extremely helpful in local inflammatory responses. When it comes to inflammatory responses, there's also systemic effects, not just local effects. And the systemic effects are going to be fever, and there's a couple purposes for fever. One is it enhances pathogen growth. Two is it enhances the immune response. And three, it helps to protect the body from the bad effects of TNF alpha. There is some school of thought that says you should never take any fever lowering agent unless the fever is like, 106, because you're inhibiting the body's response and its ability to fight off whatever the pathogen is. In addition to fever, you're also going to get what's called the acute phase response, which is the release of certain proteins by the liver. Three main ones: CRP, which is C reactive protein. Again, C reactive protein binds to phosphocholine, a substance found in the cell wall of certain bacteria. It's going to release mannose binding lectin, which binds to mannose, which is a sugar molecule in the cell membranes and cell walls of certain bacteria. And then it's also going to release a certain kind of lung surfactant, not the ordinary lung surfactant, but a kind that has an antibacterial property to it. A third effect would be increase in white blood cells, and then an increase in what's called the ESR, or erythrocyte sedimentation rate. Sometimes it's called SED rate for short. Um, if we want to know whether a patient is having any inflammation, we can check these things. So, if someone has a fever, what are you going to think? Well, there's an inflammatory process. Chances are there's an infection. It might not be an infection, but there's definitely some kind of inflammatory process going on. Um, you can also check levels of CRP. If CRP levels are high, that means there's inflammation going on. It doesn't tell us what kind of inflammation, but it tells us there's inflammation. If there's white blood cell count is high, that tells us there's some kind of inflammatory response going on. A lot of times it's associated with infection. It's usually the number one cause, but it's not always the number one cause. Or sorry, it's not always the cause of this our particular patient. But anytime you see white blood cell count high, the first thing you should think is infection. And then finally, the ESR is a non-specific measure also, which means that you don't know what's causing the inflammation. You just know that it's high. We're going to talk about ESR in a little bit more. So the way that erythrocyte sedimentation works is you take a small amount of blood and you set it in a small tube, and then you watch how long it takes for the white blood cells to settle toward the bottom. When there's inflammation going on, there's additional molecules that are produced, and those are going to stick to the erythrocytes, and it's going to make them settle faster than usual. So the sed rate is going to go up. Um, and again, it's non-specific. It doesn't tell you anything about why the patient has inflammation. It just tells you that they have it. All right, let's talk a little bit about septic shock. Now, septic shock really is the story of TNF alpha. Earlier, we talked about TNF alpha, how it makes a lot of sense for localized infections, because what it's going to do is it's going to cause vasodilation in the area, get more blood flow to it. It's going to cause increased vascular permeability. It's going to allow proteins to go out of the blood into that area, and it's going to induce clotting, which is going to help wall off that area and prevent any pathogens from getting into the rest of the body. But when TNF alpha is released directly into the bloodstream, you're going to have a whole different set of issues. So, septic shock comes from the patient being septic, and septic means that the patient has an infection in the blood. So our patient doesn't just have an infection in their tissues, like say a wound, but it's actually in the blood now. The bacteria is in the blood. So if you recall, there's two major organs that are responsible for filtering the blood in terms of infectious agents, and that's going to be the liver with your Kupffer cells, and then the spleen is going to be the primary organ. So when the large amounts of macrophages in the spleen and a few in the liver detect that there are bacteria in the blood, they're going to start to release TNF alpha directly into the bloodstream. And that's going to cause those good things that TNF alpha does to become bad things. When they're local, they're good. When they're systemic, they're bad. So you're going to have dilation everywhere that's going to cause low blood pressure. And at the same time, you're going to have the increase in vascular permeability. That's going to cause a decrease in osmotic pressure throughout the body, leading blood volume to be exiting the blood vessels and going into the tissues. So it's going to cause edema formation throughout the body. Those two things together are going to cause low blood pressure and by themselves can kill our patient. And if that wasn't enough, TNF alpha also induces clotting, and that's going to lead to something called disseminated, which means spread throughout, intravascular, inside the blood vessels, coagulation, clotting, DIC. So, clotting throughout the blood vessels. So, spontaneously, what's going to happen is you're going to get blood clots all over the body. And what that's going to do is going to burn up the body's small supply of clotting factors. And once those clotting factors are gone, then the patient is going to begin to bleed to death. For those of you who have been reading Your Coming Plague, what you're going to notice is that this is actually the exact same mechanism by which hemorrhagic fevers like Machupo virus and Ebola virus work. They work by depleting the body of clotting factors and platelets, and when they're all gone, the patient can't stop bleeding. So the patient who has septic shock is going to have low blood volume, they're going to have vasodilation, and then they're going to bleed to death as well. To treat the patient, we're going to do a couple things. We're going to have to cause vasodilation, and we're going to have to give them a large amount of fluid, and we're going to give what's called plasma expanders. So it's not just enough to give them, say, saline. because that is going to exit the blood system because of the decrease in osmotic pressure. You actually have to give them something that's going to increase the osmotic pressure. So it's got to have something that has albumin in it. So you also want to give clotting factors and platelets. So the drug, or sorry, the fluid of choice is going to be what's called fresh frozen plasma. So fresh frozen plasma is blood that has had the red blood cells and white blood cells removed from it, and also the platelets. All that's left is the water, the electrolytes, and then it's going to have clotting factors in it as well, because it's going to have all of the proteins in it. It's just not going to have it's not going to have any of the red blood cells, white blood cells, or platelets. Everything else is still in the blood, including clotting factors and albumin. So it's going to, when you give fresh frozen plasma, it's going to increase the blood volume, it's going to increase the osmotic pressure, and it's going to help the patient be able to continue to clot. With a patient like this, what you're basically trying to do is keep them alive long enough so that the antibiotics can kick in and clear the infection. It's very common when you have a patient who's in DIC because of septic shock to receive 17, 20 units of blood and fresh frozen plasma. So you're talking 40 units of blood products. That's a lot of blood product. It's expensive and it's life-threatening. This is extremely dangerous. And one final note, DIC can be caused by other things beyond just septic shock. The main one that you need to know about is in pregnant women, it can be caused by preeclampsia. This slide is extremely important for your test. Um, what it tells you is what it's trying to show you is that if you have an infection, or let's say that you have a patient who's been immunized, early on they're going to have high IgM levels. Later on, they're going to have relatively high IgG levels, or higher IgG levels and low IgM levels. If they ever get the disease again, then you're going to see something that looks like this. You're going to see a huge amount of IgG and a relatively small amount of IgM. What this does is it allows us to take a patient's antibody counts and see if IgM is high and IgG is low. That's a sign that this is a very new infection. It's the first exposure. If, on the other hand, IgG is high and IgM is low, that's going to tell us that this is a secondary exposure, so the patient is either immune from a previous exposure, or they've been immunized, or this has been a chronic type of infection. All right, let's talk immunization. There are two major kinds of immunizations. There's active and there are passive. Active, active, we're going to activate the body's immune system against the invaders. And the goal of that is to form memory cells. So what we're looking for is T helper 2 cell formation that is going to direct B cells to become plasma cells. Plasma cells are the fully mature B cell that's going to produce high quality antibody. So that's the goal, and that's actually how we know whether the immunization has been successful or not. If it's been successful, we're going to see a high level of IgG being formed against whatever we immunize them with. One thing to note, that just because you're producing antibodies does not actually mean you are completely immune from something, but it's the best that we have as far without actually exposing you to the disease and seeing, well, did it work or not. Passive immunization, on the other hand, is the injection of antibodies to offer a limited support against an invader. So an example here would be if a patient is exposed to rabies. By the time, if you try and give a patient a rabies shot or a rabies vaccine, where it's going to stimulate their own body to produce antibodies against rabies, by the time their body is producing the rabies antibodies, the patient will already be dead. So when you have a patient who's been exposed to rabies, what you have to do is you actually have to inject them with already formed antibodies against rabies. That's going to buy them time for the regular immunization, the active immunization, to do its job and have the body produce antibodies against the rabies. So, passive immunization can also take place by not simply from the injection of antibodies, but also in mother's milk. So when a baby is a newborn, the very first milk produced in any given feeding is much thinner and is called colostrum. Colostrum has a lot of IgA antibodies in it. Just an example of some of the controversy. You've probably heard some of the things about measles and all of the, well, if we had immunized and how come all this is happening. As it turns out, with the measles vaccine, if you immunize a child younger than 15 months, they're not going to respond to measles at all. They're going to get sick a little bit, have a little bit of reaction, but they're not actually going to create antibodies against the measles. So you can't immunize a child who's younger than 15 months with the measles vaccine. So that allows an opportunity for people to get the measles early in life. Now, the hysteria that's happening is these kids who are getting measles are very, very young, and we can't immunize them yet. So if only these evil parents who had not immunized their own kids had gotten their kids immunized, then they wouldn't be able to infect my little 12-month-old baby yet, because I'm a responsible parent who immunizes my children. As it turns out, there's actually some evidence to show that when we inject patients with immunizations, especially for measles, this isn't necessarily across the board, but specifically for measles, that it's different than actually getting the disease. When you get the disease, measles, what you get is a large number of T helper 1 cells, which are going to develop B cells differently than T helper 2. They're also going to be highly effective at managing macrophages. When you give an injection of the measles vaccine, you don't get the same kind of immune response. What you get is you get a large number of T helper 2 cells, but not a lot of T helper 1 cells. So you're going to produce antibodies, but you're not going to have the same kind of T helper cell maturity that you will with actual disease. So what the research shows is that if a mother had the measles when she was a child, when she's producing breast milk, her colostrum will actually have antibodies against measles in it. But if she has been immunized against measles and never actually had the measles, then she's not going to be producing the correct amount of IgA antibody against measles to be able to transmit that immunity to her child. And that is why these children who are very, very young, who are too young to be immunized, are susceptible to getting measles. So, is the correct answer to get everyone immunized so that there's increased herd immunity, or would it be better just not to immunize people against measles at all, unless they're very high risk, and allow patients to get the measles as a childhood illness again? And the answer is nobody really knows, even though everyone's going to sound like an expert on it. Okay, finally, we're going to talk about two different kinds of vaccines that are not the typical vaccine. So, just to be clear, the typical vaccine is an active immunization. Practically all of the immunizations you've gotten your entire life are active. The measles, the mumps, rubella, tetanus, varicella, hepatitis B, Haemophilus influenza, hepatitis B, hepatitis A, all of these things you've gotten throughout your entire life, they're all active immunizations. Now, tetanus is an interesting case. It doesn't actually immunize you against the tetanus bacteria. What it does is it immunizes you against the tetanus toxin. So just to recap about tetanus, tetanus is a bacteria that produces an exotoxin that can cause paralysis. It causes muscle spasms called tetany. Tetany is not the same as tetanus. Tetany is muscle spasms, and that muscle spasms cause a person to become paralyzed. In particular, they can't eat when they have it, and that's why it used to be called lockjaw. So the vaccine against tetanus doesn't prevent the bacteria from developing and growing. What it does is it prevents the tetanus toxin from being toxic. So let's imagine for a moment that we had a knife. Now, does the entire knife do damage, or is it just the pointy end? Well, it's just the pointy end. The handle is safe. So what if we created a vaccine that consisted of just the handle and no blade? So now what's going to happen is you're going to produce antibodies against the handle. So now when you get infected with tetanus, and tetanus is producing the entire toxin, including the pointy end, now you've got antibodies that attack the handle, and that's going to opsonize the entire molecule and neutralize the entire molecule, preventing it from causing harm. So when you take a poison and you cut off the dangerous end, that's called a toxoid. So in this case, what you have is a tetanus toxoid vaccine. And the last thing is an example of a passive immunization, and that would be antivenin. So if you are bitten by a rattlesnake, eventually your body will produce antibodies against the venom of the rattlesnake. But you might not have that much time, and it's an extremely painful process to go through. So what we can do is we can pre-manufacture antibodies against the rattlesnake toxin. And the way that we do that is by injecting horses with small amounts of rattlesnake venom. The horses will produce antibodies against that venom, and then we spin down their plasma, and we've got the antivenin ready for when you're stupid and you handle a rattlesnake and it bites you. And finally, of course, just need to reiterate that whenever we're talking about injecting antibodies into a patient, we don't use the word antibodies, we use the cool word immunoglobulins. So if you ever see a patient who's receiving immunoglobulins, they're actually getting a passive immunization. This is another thing you need to know, primary intention. Primary intention is when you close the skin, when there's a wound, you close the skin together and it's going to heal from the outside in. So anytime you hold the skin together, such as with stitches or staples or with glue or even steri strips, you're creating a primary intention environment. Primary intention healing is going to typically be faster and involve a smaller scar than secondary intention. There's also less risk of infection because the skin is actually closed from the beginning. The major disadvantage to primary intention is that if there is infection already inside the wound and you put the skin together over it, you're going to create a pocket of infection, and that can lead to extremely dangerous situation. So the general rule of thumb is that if a wound has been existent for at least 8 hours, then you're no longer going to use primary intention. So you've got to leave it open and let it heal from the bottom up. The other downside of primary intention isn't necessarily a downside, but it's just if the skin breaks open, if the wound pops open, which we call a dehiscence, then you've got to let it heal by secondary intention. So it's important to tell patients who have primary intention healing that they need to take it easy for a couple days or even a week or more so they don't split the wound back open. Secondary wound healing is when the wound is left open and so it's not being closed up by sutures or staples or any other method. It's going to take a lot longer for it to heal. You're going to have a much larger scar, and it's open for infection the entire time. Sometimes it's going to form underneath the scab, and then the scab can sometimes actually inhibit healing depending on how big the scab is. Okay, next we have hypersensitivity reactions. Hypersensitivity reactions are sometimes called allergies, and there's four types. For the test, you're going to need to know the number, the name, how it works, and at least one example. So you're going to need to know the name, the number. So number one is anaphylactic type, or sometimes called vasoactive. Number two is called cytotoxic. Number three is called immune complex. And number four is called cell-mediated. You've got to have the names, the numbers, and then you also need to know the mechanism of each one and an example of each one, preferably more than one. Anaphylactic reactions are used to be called immediate allergic reactions or hypersensitivity reactions, and what it requires you to have had a previous exposure where IgE was produced. The IgE was embedded into basophils and mast cells, and the next time you were exposed to that same substance, when the IgE antibodies um, bind to that substance, they cause degranulation of the basophils and of the mast cells. That's going to cause a huge release of histamine coming into the body, and the end result is going to be vasodilation, increased vascular permeability. So the patient's going to have decreased blood pressure because of the vasodilation. They're going to have decreased blood volume due to the vascular permeability. But the really, really dangerous thing is actually not either of those. It's the swelling in the throat. Laryngeal edema can actually cause asphyxiation because it can make the airway swell up so much the patient can't breathe. The treatment in general for anaphylactic or vasoactive type reactions is going to be antihistamines. If they're severe, if the patient actually goes into anaphylactic shock, then the treatment is going to be epinephrine. And then you can also treat by using allergy shots. And the whole mechanism of an allergy shot is by very small amounts of exposures repeatedly over time. You're trying to shift the body from T helper 2 cells to T helper 1 cells. And then the T helper 1 cells will no longer produce IgE, they'll no longer direct the plasma cells to produce IgE, and they'll produce more IgG. So you'll still actually have an allergy to whatever it was, but you'll no longer have that vasoactive reaction any longer. There are a lot of common anaphylactic reactions or vasoactive reactions. Um, Pretty much all insect stings have some kind of vasoactive reaction to them. Even if you've ever been bitten by a mosquito and you have that little welt that comes up, that is actually a vasoactive reaction. Um, so you can see the list here of all the different ones, and it's interesting to note that hives and allergic rhinitis and atopic dermatitis and asthma are all actually the same disease process, just to different degrees and in different areas. The next hypersensitivity reaction is called cytotoxic. In cytotoxic, you're going to have antibodies that are being produced against antigens on the host cell. So basically, you're producing antibodies against yourself, or at least certain tissues or organs. The host cells are then going to be destroyed by complement and by phagocytes like macrophages. Some very common disorders that involve cytotoxic reactions include blood rejection from blood mismatch, myasthenia gravis, which we talked about earlier in the semester, where we have the body producing antibodies against neuromuscular junctions or nicotinic M receptors. Also, type 1 diabetes, where you have the body producing antibodies, against the beta cells in the pancreas, and the beta cells are what produces insulin. Next, we have immune complex, type 3 immune complex. And in immune complex, what we have is an antibody binding to an antigen, and that forms what's known as the immune complex. Now, remember, the purpose of an immune complex is, among other things, to activate complement. So typically what will happen is um, sometimes that immune complex doesn't stay where it's supposed to stay. It doesn't stay blocked off. It escapes into the blood or into some other part of the body. And then when the complement cascade activates against that complex, it's going to cause inflammation or an immune response somewhere else in the body. So it's kind of like collateral damage. So collateral damage is when you are fighting someone and you destroy something else by accident. So let's say that you're fighting with your brother, and by accident, you know, one of you hits the glass door and the glass door breaks. You didn't mean to break it, so that was collateral damage. So in this case, the body isn't meaning to damage itself. It just, it just kind of happened because, well, the immune complex was there and I had to hit it. Some common things that are a result of immune complex would be systemic lupus erythematosus. A lot of the autoimmune disorders that women tend to get, like lupus, rheumatoid arthritis, those are all immune complex. And then Stevens-Johnson syndrome, which we mentioned for sulfa allergies, that is also an immune complex. Read once that, or actually didn't read it. I was at a lecture once where an allergist said that something like 90% of all food allergies are actually immune complex, not vasoactive. The vasoactive are the ones that get all the press because if you're allergic to peanuts and your face swells up and you die, well, that's kind of, everyone got scared, everyone was very dramatic. But most food allergies are actually just immune complex, and so you eat some food and you think that it upset your stomach, but really what it was it caused an immune reaction, and that inflammation upset your stomach. Um, Celiac disease is also an example of immune complex. And in celiac disease, you've got an allergy against gluten. So as the antibody attaches to the gluten molecule, the gluten protein, then that's going to cause activation of complement and cause local inflammation in the gut. And that can cause a whole number of other problems. The last reaction is called cell-mediated. So type 4 is cell-mediated. In this case, remember cell-mediated always refers to T cells. So in cell-mediated, T cells are going to stimulate macrophage activity against the body. And that's going to cause damage in that area. And if it consists, eventually you can cause granulomas to form. So some common examples of this would be allergic dermatitis. So if you are allergic to cheap jewelry, that's actually a cell-mediated allergic reaction. Poison ivy. So there's some people, poison ivy, the actual toxin is an oil that the plant secretes. And that oil, some people don't react to it at all. Their immune systems just won't attack it, and it doesn't cause any problem. It's the immune reaction against the poison ivy is what causes the problem. And so allergic dermatitis, any type of allergic dermatitis, including latex allergy, is going to be cell-mediated. And then also tissue transplant rejection is also cell-mediated. When it comes to anti-inflammatory and anti-immune drugs, we have kind of two categories. Anti-inflammatories are going to inhibit um, inflammatory mediators, and then the anti-immune drugs are going to inhibit the actual immune system, typically by destroying T cells or preventing their proliferation. Steroids do both depending on the dose. At smaller doses, they are anti-inflammatory, and at higher doses, they are anti-immune. We are actually not going to talk about the anti-inflammatory drugs too much in this particular section. We're going to talk about NSAIDs when we get to pain, and we're going to talk about leukotrienes when we get to asthma, and we're going to talk about thromboxane drugs when we get to platelets, and we're going to talk about antihistamines. We'll probably mention that right now, but the main place we're going to talk about them is for respiratory. The first class of anti-immune drugs is calcineurin inhibitors. Now, calcineurin is the substance that is needed to produce interleukin 2. Interleukin 2 is a cytokine that tells T cells to proliferate. Remember, we don't want T cells just proliferating anytime they feel like it. We only want them to proliferate when there's a need for them. So one of the ways the body is going to moderate the amount of T cell production is by the production of this interleukin 2 substance. The more interleukin 2, the more T cells. The less interleukin 2, the fewer T cells. So the main use for calcineurin inhibitors is in patients who have immune diseases. So transplant graft rejection, so if they've had a liver or kidney transplant, heart transplant, we'll often use it for patients who have had that. We'll also use it for patients who have psoriasis or rheumatoid arthritis, which are also autoimmune diseases. Two particular drugs that you need to know. The first one is cyclosporine. Cyclosporine was the very first one that was discovered. It's not really used as often anymore because the newer drugs are less toxic and they work a little bit better than cyclosporine does, but it's still a classic. When I was in nursing school, this drug was the number one drug that was being given at the time, and it was costing $15,000 a day or something crazy like that. Maybe it was the bottle was worth $15,000. Main adverse effect is nephrotoxicity, and of course, anything that inhibits the immune system can cause infection. Newer drug in the same class, the calcineurin inhibitor, is Tacrolimus. This drug used to be called FK506, and that was actually still being experimented on when I was in nursing school way back in. So now it's no longer on patent, and so it's much, much more commonly given. An interesting little side note about tacrolimus is that you can actually get it in an ointment form called Protopic that you can use for rashes like rheumatoid dermatitis, or sorry, for contact dermatitis such as poison ivy. There's a newer one out called pimecrolimus, and that is available in a cream called Elidel. And since I mentioned ointment and cream in the same sentence, ointments are petroleum based, so they're like a petroleum jelly based, whereas creams are water based. The next class of drugs are called cytotoxic drugs, and these are drugs that are going to kill fastly proliferating cells, primarily B cells and T cells. However, they can also kill other rapidly dividing cells, such as skin, epithelial cells, and red blood cells. So that should tell you what a lot of the adverse effects are. The adverse effects can be low red blood cell count, anemia, that can cause skin breakdown, they can cause epithelial destruction. So, some examples: azathioprine, cyclophosphamide, methotrexate, and mycophenolate. All of these drugs are used to destroy fast-growing B cells and T cells. Interestingly, a lot of these can also be used to destroy cancer cells because cancer cells are also rapidly dividing. The drug for you that you need to know for your test is going to be azathioprine. Later on, in Pathopharm 2, when we get to cancer, you're going to learn a little bit about methotrexate. One note about glucocorticoids is that sometimes they are called corticosteroids. So, cortico comes from cortisol like. Steroid is the molecular structure. So, a glucocorticoid is a cortisol substance that affects glucose, and then corticosteroid is a cortisol substance that has a steroid shape. They are exactly the same thing. They're just synonyms for each other. It's just usually depends on who's the person talking. I usually say corticosteroids, but sometimes you'll hear me say glucocorticoids. They are exactly the same. The next drug we're going to talk about, or the next class of drugs we're going to talk about, are glucocorticoids. So, the gluco means that they regulate glucose, and cortico means that they come from the adrenal cortex. So, if you recall, in the adrenal cortex from ANP2, you've got three hormones being produced. You've got the mineralocorticoids, which are primarily aldosterone. Then you have the glucocorticoids, which is primarily cortisol. And then you have sex hormones, which is going to be either estrogen or testosterone, depending on the patient's gender, or rather the patient's sex. So, glucocorticoids are basically artificial cortisol. So, cortisol has a lot of effects on the body. So, when it comes to pharmacological effects, what we mean by pharmacologic effects is when we're giving large amounts, it's not going to act the same as cortisol does in the body. So, you can give what's called physiologic effects for a patient who doesn't have enough cortisol in their body. So, for example, a patient who has Addison's disease doesn't produce enough cortisol, and you give just enough to replace the cortisol, that's a physiologic effect. But when you're giving large doses, that's going to cause pharmacologic effect. And the primary pharmacologic effect, and the reason why we give them, is for their anti-inflammatory and anti-immune effects. They're going to inhibit prostaglandins, leukotrienes, and histamine synthesis. They're going to suppress infiltration of phagocytes, so there'll be fewer macrophages and neutrophils going to whatever the area is, and it's going to suppress the proliferation of lymphocytes. If you give them in even higher doses, they'll actually kill lymphocytes. In addition to the anti-inflammatory effects, we're also going to have effects on metabolism and electrolyte. So, glucose levels are going to rise, protein synthesis is going to be suppressed, and then fat deposits will be metabolized. And then there's going to be a lot of electrolyte effects. Patient will typically have higher sodium levels. It's one of the things that can happen. Because of the higher sodium levels, the patients can have fluid retention. Because of the fluid retention, they can have hypertension. So basically everything is high except for protein synthesis, which is low. Some of the therapeutic uses for steroids include rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease such as Crohn's disease or ulcerative colitis, miscellaneous inflammatory disorders. So if there's inflammation involved, you can use steroids for it. Allergic conditions, but not acute anaphylaxis because the patient will die while they're waiting for the steroid to kick in. Asthma, dermatologic disorders. So basically any rash. There's a saying in dermatology, you know, if they're on steroids, take them off. If they're off steroids, put them on. So pretty much any rash, you might want to try steroid on it and see what happens, maybe. No, that's not the correct way to do it. Right here, this neoplams, that S is out of place. It should be neoplasm, which is a cancer. Transplant rejection, they're used to help prevent transplant rejection, and then they are also used for preterm infants. This preterm infant requires a little bit more explanation. So the last thing to develop on a baby before they're born is their lungs. And actually the lungs don't fully mature until that baby takes its first deep breath in after being born. Um, and what causes that last final maturation is cortisol. So the birth process is very stressful. That produces a lot of cortisol, and then that is going to induce the final maturation so the baby can take that first breath and scream, "Put me back inside." Um, if you have a baby that's being born prematurely, their lungs are not going to be ready to breathe oxygen, or, well, any air really. So what we can do to help mature those lungs is we can give the mother a steroid, and then the baby will absorb that through the umbilical cord, and that will help to mature their lungs at least a little bit so that they have a better chance of surviving once they're born. So this is not something you do just because, this is what you do when you think, that baby's coming out and we got to be ready for this. It's not something that you do just because, we think they might be a little premature. You're going to wait on that. And we don't give it to the baby, we give it to the mother. Okay, so let's talk a little bit about the immunosuppressive effect. When you give steroids in large doses, you're going to actually cause destruction of B and T cells. You're going to trap the T cells wherever they are. You're going to reduce the amount of interleukin 2 production, which is going to reduce the number of T cells even further. And you're also going to reduce their responsiveness to interleukin 1, which is going to reduce their activity in the immune system. All that to say that in very large doses, steroids have an incredibly broad effect on the immune system. Now, just how big are we talking here? As an example, one of the drugs you're about to memorize is called Methylprednisolone. When you give it IV for an anti-inflammatory purpose, you typically are going to give somewhere between 5 milligrams and 60 milligrams. When you give it for a patient who is having rejection, transplant rejection, immunosuppression in this case, you're going to give somewhere between 500 and 1500 milligrams. So it's a huge dose compared to the normal anti-inflammatory dose. All right, let's talk adverse effects. The first one is adrenal insufficiency. So you remember that cortisol comes from the adrenal gland. Um, Cortisol is not produced all the time. It's only produced when the adrenal gland is told to produce it by the pituitary gland through ACTH, adrenocorticotropic hormone, which I know you guys remember from A&P2. So what happens when you're giving large doses of steroids is that the pituitary says, hey, we got a lot of this stuff on board. We don't really need any cortisol right now, and it stops producing ACTH. That in turn tells the the adrenal gland to stop producing cortisol. So if you take the patient off the steroid suddenly, the patient will go into an adrenal crisis because they're not going to have any cortisol in the entire body. So the take-home message is we never, ever go off a steroid suddenly. What we're going to do is we're going to taper down slowly. So if they're, let's say that they're on a 10 milligram dose, we might go down to 5, and then the next day down to 3, and then the next day down to 2, and the next day down to 1, and then the next day they go off them. And that's going to avoid that adrenal insufficiency crisis. In long-term therapy, steroids can cause osteoporosis because they inhibit calcium formation in the bone. They're basically going to decalcify the bone. Um, I know a woman. She's not a patient, but she's not even a friend. She bought my car. She came to the car and she's how talking about all these horrible problems she's had with her health, and she said, I used to be 6 inches taller. And it turned out that she got systemic lupus erythematosus, and she was being treated with steroids, and the steroids ended up causing osteoporosis, and she had a lot of fractures in her spine, which caused chronic pain, and then also caused loss of height and interfered with the ability to breathe. So this is not just a small thing. It's not like, oh yeah, your risk of having a fracture is higher now because you got a little osteoporosis, so try not to fall. It's much more serious than that. Infection, it makes sense. I mean, after all, these are anti-inflammatories and anti-immune drugs, so they can increase the risk of infection. Glucose intolerance, basically because one of the effects of steroids is to increase glucose levels, now all of a sudden your patient can have high glucose levels and can mimic diabetes. Myopathy, it can cause muscle damage because of the suppression of protein synthesis that can actually cause muscle pain. Fluid and electrolyte disturbance, primarily through sodium. Remember that can cause elevated sodium, and that in turn can cause fluid retention, which in turn can cause hypertension. Growth retardation in children. Children who take chronic steroids are going to grow slower than kids who don't. Supposedly, they'll reach their ultimate, what's called terminal height. So if they were supposed to become 6 foot, they'll still become 6 foot. It's just gonna, instead of being 6 foot at age 15, they're gonna be 6 foot at age 17. That's the theory. I don't know exactly how they determine this, but that's what they think. And then finally, it can cause psychological disturbances. The psychological disturbances can actually cause dementia and altered thought processes. But wait, there's more. Remember how we said that it can cause protein metabolism problems? Well, in that, it can also cause cataracts, which are protein growths over the lens of the eye. And it can also cause glaucoma, which is an increase in the pressure inside the eye. That in turn can lead to decreased peripheral vision, and if it goes on long enough, can actually cause decreased central vision. It can cause peptic ulcer disease because it can inhibit the stomach lining, which is formed in response to prostaglandins. So when steroids suppress prostaglandin production, they also inhibit the mucus production of the stomach. And it can cause iatrogenic Cushing's disease. What the heck is Cushing's disease, you ask? Cushing's disease is caused by excess cortisol levels. It's often caused by a cancer or tumor of either the adrenal gland itself or of the pituitary, which creates too much ACTH. Patients who have too much cortisol basically look like patients who have too much steroid. They're going to have elevated blood pressure, elevated blood glucose. They're going to gain weight, and they're going to have fatty deposit changes. So they're going to end up getting fatty deposits in the face, in the neck, and in the belly. So they call it central adiposity. So remember, adipose means fat tissue. So you're going to get three places where you're going to get fat deposits: the abdomen, the face, and the neck, back of the neck. The back of the neck, they sometimes call that buffalo hump. The face, they call it moon face. And then the stomach, well, a lemon. And because of the decreased in protein synthesis, patients who are on chronic steroids also tend to have muscle wasting. They're going to have less muscle mass. And so the kind of the classic appearance is toothpicks on a lemon, where the toothpicks are their arms and legs, skinny little arms and legs with no muscle. You can counter a lot of these adverse effects with exercise. In addition to that, you can also have ischemic necrosis, especially with patients who have high levels of alcohol consumption. So alcohol consumption plus steroids may cause ischemic necrosis, which is going to cause death of the bone marrow. That in turn could cause hip replacement or other joint replacements because you've actually killed the bone. And finally, when it comes to decreased protein metabolism, you're also going to have decreased wound healing. Now, the decreased wound healing is a combination of factors. One is the decreased inflammation. Remember, inflammation prepares the body to become healed. And the second is going to be because of the inhibition of protein synthesis. So in this case, wounds, you got to heal them with collagen, and collagen's a protein. You can't make the protein as fast. You're not going to heal as fast. So steroids are no joke. Um, if you're on them for a day or two or a week, probably not going to cause that big a deal. You might need to check your blood pressure, your heart, or your blood glucose, but for the most part, not a big deal. All of these side effects become a problem when the patient's going to be on them long term. So, one note with long term therapy is that we try and use the least absorptive method possible. So, if we're treating allergic rhinitis or if we're treating asthma, we don't want the patient to receive a systemic steroid. We want them to receive an inhaled steroid in the case of asthma or a nasal steroid in the case of allergic rhinitis. So that will decrease the amount of absorption, so it'll decrease the amount of systemic side effects. All right, let's talk some drug names, shall we? For your test, you're going to have to know cortisone and hydrocortisone. Those are what's called a one-to-one. So they basically have the same strength as cortisol itself. They're one-to-one with cortisol. In fact, hydrocortisone essentially is artificial cortisol. Cortisone is basically a prodrug that turns into hydrocortisone in the body. Cortisone is absorbed by the mouth, and it's the most commonly used drug for a patient who needs to be treated because they don't make enough cortisol on their own. Hydrocortisone is available over the counter, and it's available primarily in creams and ointments, and that's going to make it the number one used in the world just because you can get it without a prescription. Next, we have what are called the intermediate acting, and these are going to have an anti-inflammatory power of 4 to 5 times the amount of action that cortisol has. So they're 4 to 5 times more potent than cortisol. They produce a much higher level of of inflammation suppression. The two most common are going to be prednisone and methylprednisolone. Prednisone is the most common oral steroid. Methylprednisolone comes in both oral forms and IV forms. The brand name is Medrol, 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 and when you use it for injection, it's going to be called Medrol. So, solu like solution. So, Medrol is just methylprednisolone in an injectable form. One thing about methylprednisolone is that once you put it in water, it becomes unstable and can begin to degrade fairly quickly. So the way that it comes in this little vial that's a powder on one end, and then there's a little rubber stopper, and then there is a small amount of saline on the other side of the stopper. So before you give it, you're going to squish the two parts together, and that's going to allow the fluid to mix with the with the powder. Make sure it's all dissolved, and then give it. And the purpose for separating them like that is to make the powder last longer, because in solution, it's an unstable solution. And then finally, we have two that are long-acting and very high potency, and those are betamethasone and dexamethasone. They're going to be about 20 to 30 times stronger than cortisol. Betamethasone can be used for a number of things. The main thing that you're going to know about is we use it for preterm labor. So we give it to the mother, not the baby. You have to give it before the baby is born, not afterwards. And the purpose is to induce maturation of that premature infant's lung. Dexamethasone is kind of like the most commonly given in the hospital, especially for cancer patients. Two things it's going to do for cancer patients. One is it's going to help them feel better, and it's going to help their nausea medication work better. And the other thing that it can do is it actually can kill some cancer cells, especially leukemias.